Good afternoon. This is Matt Schreiber at myMatrixx, and I'm happy that we're able to provide you another one of our webinar series. Today we will be discussing the navigating of medical marijuana in workers' compensation. In today's session, it's going to be 1 hour in length. It will be recorded and available in about a week online at www.mymatrixx.com. It's available for CE credits, and that's for adjusters in California, Florida, Georgia, and Texas. Also for certified case managers, RNs, except for in Iowa. An email will be sent out within the next 3 business days so you can register for your CE credits. And if you have any questions, please submit those in the chat panel, in the chat pane. We will do our very best to answer as many of those as we can. We've already received some prior to today's meeting. Again, I'm the moderator today, but our presenters are going to be Phil Walls, who's our Chief Clinical and Compliance Officer, and Michael Wynn, who's our Director of Clinical Pharmacy. As many of you may know, Phil is our Chief Clinical and Compliance Officer, and he oversees all of our clinical programs here at myMatrixx. He's got 25 years of experience in pharmacy and healthcare informatics. He's a published author. He focuses heavily in the opioid world, and he's received the 2011 Dorland Health People Pharmacist Award. And he's also a pharmacist from Mercer University's School of Pharmacy, as well as a doctoral candidate from the Ohio State University. Michael Wynn is the director of our clinical pharmacy programs, and he manages all of our drug regimen programs, as well as he's an assistant clinical professor at the University of Florida, and he has a bachelor's degree in chemistry and has his pharmacy degree from Mercer University as well. Today's agenda is going to bring us into a quick background of marijuana itself, federal and state laws, marijuana as a medicine, the implications that employers have with it, the implications within workers' compensation, some best practices, and then conclusion and questions. And with that, I hand this over to Phil.
Okay, Matt, thank you very much. Looking at the background of marijuana, it's important to point out that we're talking about the leaves and buds of the plant called Cannabis sativa. This, in and of itself, is not unusual. It's simply something very unusual for the 21st century. Prior to World War II, plants were a primary source of most medications. And in fact, all of the most potent medications in use today are derived originally from a plant source. A great example of this is the drug digoxin, under the trade name Lanoxin, very potent medication used in treating heart failure. Prior to the development, though, of digoxin, it came from a natural plant source known as foxglove. Physicians would brew it as a tea. The patient would consume it in that way. And yet I don't think any of us could conceive of a patient drinking a remedy for something like congestive heart failure today. So the fact that we're having this discussion about a plant is very, very interesting in the 21st century. So keep that in mind as we go through when we think about standardization and quality control, how to look at the outcomes from different studies. Remember, this is from a plant source. There's no way of validating the amount of drug between different lots, so to speak. Primary ingredient is known as tetrahydrocannabinol, the abbreviation THC. Contemporary uses today, unfortunately, one that's considered recreational. It is also used in some religious and spiritual rites, and regardless of your opinion on the subject, it is being used as a medicine. What we know, based on a survey from 2009, is that 16.7 million Americans over the age of 12 have used marijuana once during the months prior to the survey. So a significant number of people. This is the world's most popular illicit drug. When we look at the fact that the United States consumes 2/3 of the world's supply of illicit drugs, and marijuana is at the top of that list, we have to keep in mind we're not talking about the tip of the iceberg here. We are talking about the iceberg. Now, of course, cannabis is covered by the Controlled Substance Act. This was part of the Comprehensive Drug Abuse Prevention and Control Act of 1970. The purpose of this act was to regulate the manufacture, importation, possession, use, and distribution of certain substances. There are 5 schedules that address how this is handled, and it's up to the DEA and the FDA to maintain scheduling. The DEA and the FDA being federal entities, of course, not state entities. The scheduling can change through legislative amendments, and states can also maintain separate classification. Some of the better examples of that is some states treating soma as a controlled substance versus a non-controlled substance at the federal level. Now, there has been petitioning regarding marijuana and its position as a Schedule I controlled substance. An organization in 1972 called the National Organization for the Reform of Marijuana Legislation, otherwise known as NORML, supported the decriminalization of marijuana. They were unsuccessful in petitioning the Bureau of Narcotics and Dangerous Drugs to move marijuana from Schedule I to Schedule II. The BNDD was the organization that preceded the DEA. But that didn't end this movement, so to speak. One of the more recent ones was by the American Safe Access Group. They currently have a petition in front of the Court of Appeals, and that court actually began hearing arguments on October the 16th of this year. So keep that in mind. This is very current. So as things develop, this could have a huge impact on the debate over medical marijuana. Now, we've been talking about schedules. Let's look at these for a minute. There are 5 schedules. The lower the number, the more concern we have about the potential for abuse and addiction. So a Schedule I has the greatest risk of abuse, has a very high potential, and most importantly, it has no currently accepted medical use. Then as we go down the list, the next in line is Schedule II. This is where we see a lot of drugs that are used quite often in workers' compensation. Many of the opioids fall into this category. They have a high potential for abuse as well. The difference between them and Schedule I is that they have an accepted medical use, but their use or their abuse may lead to severe psychological dependence. As we go down the list, Schedule III has less potential than Schedule I and II, and the abuse could lead to moderate or low physical dependence. Schedule IV, less abuse potential than Schedule III, and so on. Schedule V has less abuse potential than Schedule IV. So keep in mind, marijuana is at the top of this list, and it's in the company of drugs such as LSD, heroin, ecstasy. So it is not an insignificant concern when it comes to addiction and misuse of this particular drug. By being a Schedule I drug, keep in mind at the federal level, possession, usage, purchase, sale, and/or cultivation of marijuana is considered illegal. Now, when we start looking at the states, California led the way in looking at making changes to the way marijuana is considered. And they did this under a proposition that is now known as the Compassionate Use Act. This was in 1996. It was the first law at a state level allowing patients to possess and cultivate marijuana for medical use. They did not go after trying to make a change in the schedule at this point in time. They were simply saying that it should be legal. Since that time, it is now legal in 17 states and the District of Columbia. And there is legislation pending in 6 other states. So although we can say that its use at the state level is still in the minority, I think it's important to point out that there are a number of different states considering this as well. Now, a number of states have looked at making changes to this, and the bills failed during 2012. As you can see, the states listed there. And then there's also a number of states that are considering decriminalizing marijuana. And of this, notice that 3 of these, the last 3 listed there, Oregon, Washington, and Colorado, are all voting on this next month. So as we said, this is a very timely subject. Things are changing even as we speak. Now, Colorado has something that is currently under review known as Amendment 64. This is a campaign that wants to look at regulating marijuana like alcohol. The important takeaway from this is looking at who is supporting this particular movement. Number 1, the Colorado Democratic Party. 56% of the Denver County Republican Assembly. The NAACP. Members of Colorado's law enforcement community. More than 300 Colorado physicians are in favor of Amendment 64, and more than 100 college professors from across the nation. The support from physicians is going to have strong implications on how we discuss the impact later on when we start looking specifically at workers' compensation. But to go ahead and set the stage, a common question that I received from my clients today is, Phil, the physician did a urine drug screen because the patient's taking opioids, and yet he or she detected marijuana but chose not to do anything. Why is that? So as I said, this is sort of helping to set the stage for why that might occur. Now, medical marijuana legislation usually includes a patient registry. As you can see from the list there, there are a number of states with an active registry. Colorado is at the top of the list based on the number of patients per 1,000 population. Michigan would be at the top of the list if we were looking at the total number of registrants. There are also 4 states that have registrations in development, but they're not yet active, but they will be mandatory. Surprisingly, California's registration is considered to be voluntary. Now that I've covered the legal status, Michael, I'd like to hand this off to you to discuss a discussion of marijuana and its medical uses.
Thank you, Phil. Well, the medicinal potential of marijuana has been a subject of a lot of research and debate, but it is known that scientists have confirmed that the cannabis plant have active ingredients that have therapeutic potentials for, 1, relieving pain, controlling nausea, stimulating appetite, or decreasing ocular pressure. The research has led to the development of cannabinoid-based medications. In the U.S., there are currently 2 FDA-approved synthetic compounds, dronabinol, it goes by the name brand of Marinol, Nabilone, brand name Castamet. Dronabinol is FDA-approved for chemotherapy-induced nausea and vomiting, and AIDS-associated anorexia or weight loss. Castamet now is very specifically approved for the treatment of nausea and vomiting associated with cancer chemotherapy in patients who have failed to respond adequately to conventional antiemetic therapies. Now, according to the official product labeling for Castamet, this restriction is required because a substantial proportion of any group of patients treated with Nabilone can be expected to experience what they call disturbing psychomimetic reactions not observed with other antiemetic medications. These reactions, Phil, include anxiety, disorientation, depression, hallucinations, and psychosis. I just want to point this out because there are problems that they are seeing with this isolated component of cannabis, essentially just the THC component of cannabis. When you're talking about smoking the plant itself, what we're talking about is subjecting our brains to over 400 other chemicals for which we know very little about. But for these two drugs that we just discussed, Marinol and Calumet, which are essentially just approved for nausea and vomiting or AIDS, according to the guidelines from the American Society of Clinical Oncology, both dronabinol and nabilone should not be used first line for any group of patients. Essentially, it should be reserved for those intolerant or refractory. Sativex is a new chemically pure mixture of a plant-derived THC. As you notice, it doesn't have a generic name. It is a non-synthetic drug formulated as a mouth spray and is currently approved in Canada and parts of Europe for the relief of cancer pain and spasticity, and also for neuropathic pain in patients with MS. But the drug, as we're going to talk about next, it's making its way or encroaching into the U.S. market as we speak. For drugs or indications that may be in the pipeline, a search of clinical trials resulted in 91 hits for various cannabis-based preparations. Now, some of these studies we should keep a close eye on because they might end up in the workers' compensation population. Of the trials that have been completed, which means that the data is being right now in the stage of being analyzed, it's going to be reviewed and possibly submitted to the FDA for approval. We see that they're evaluating dronabinol for migraines, dronabinol for fibromyalgia, and for chronic back pain. There is a cannabis inhaler being evaluated for neuropathic pain. Sativex, as we discussed earlier, is being evaluated for cancer pain and also for spasticity related to MS. Now, we should make a point that the reason we believe it may end up in the workers' comp population is that although they are studying these drugs specifically for conditions like fibromyalgia and MS, which do not have a recognized industrial origin, workers' comp doctors, they are notorious for prescribing off-label. For example, some of us may be familiar with a drug called Savella, which is an antidepressant type medication. It has been evaluated for fibromyalgia, but through inference of efficacy for neuropathic pain, it is showing up on low back pain treatment regimens. There are studies that are currently in the recruiting phase. The first of which is a dronabinol and naltrexone product for opioid dependence. The second is an oral cannabinoid-based product for fibromyalgia. So in addition to the Marinol, Calumet, and Sativex that are currently available, these studies are telling us that we can anticipate the emergence of new or novel cannabinoid-based products coming to market. The third study here is actually for smoked cannabis for MS. And the last is nabilone or Calumet for spasticity and neuropathic pain and spinal cord injuries. This one is concerning to me because I've personally seen cases where an initial report of back strain somehow progresses to a diagnosis of spinal cord injury. Typically after a surgical procedure, it was the pain complaint continues.
So Michael, I just want to make sure I'm clear. You say these studies are in the recruiting phase, and one of them is smoked marijuana?
Yes.
So you're saying they are looking for volunteers at this point to participate in these studies? I find that very surprising since this is an illegal substance at the federal level.
I'm surprised it's still in recruiting.
Yes.
Interestingly, there are 3 studies, according to the clinicaltrials.gov website, that are currently in the unknown status that could have impacted workers' comp. Perhaps the most concerning one is dronabinol as being examined as an add-on therapy for opioid therapy. According to the website, this study was started in 2005. It was last updated in 2010. And studies are marked as unknown if they have not received an update in 2 years or more. The second study was one that is examining an oral THC solution for fibromyalgia pain that was initiated in 2010, but also has not been updated in 2 years. It was supposed to be completed in October of this year, but no update yet. The last study is examining dronabinol for prevention of chronic regional pain syndrome. This study was initiated in 2008 and has not received an update in over 4 years. It's uncertain what's going on with these studies right now, but the lack of an update could very well mean that they have been discontinued or abandoned.
On the other hand, Michael, if they had continued, I think all 4 of these would have had a very clear indication to impact workers' comp. Would you say it's safe to say we dodged the bullet on these?
Yeah, but again, we really don't, it's really uncertain what the stage is. Maybe they halted it or they're going to continue it. It's really uncertain what stage they are now. Now, in regards to the use of smoked marijuana, the reports of its medical value began to appear during the 1970s. During the AIDS epidemic of the 1980s, patients found that smoking marijuana relieved symptoms associated with wasting. It's a condition referred to as cachexia. It's a very complicated condition, but wasting or loss of appetite is one of the symptoms. But during this period, patients that were charged with unlawful possession of marijuana claimed a justifiable defense or a medical necessity defense. Now, these claims were mostly rejected by the courts, but some did accept them, which likely have paved the way to the medical marijuana debate of today. Cachexia is not limited to AIDS, though. It was interesting to find during our research that nearly 1/3 of cancer deaths can be attributed to cachexia. It is also commonly seen in patients with chronic forms of kidney disease and heart failure, severe trauma, and burns. For the treatment of nausea and vomiting, an Institute of Medicine report points out that smoked marijuana is modestly effective, but in general it's not well tolerated. However, it's known that it does act in a different mechanism, and for that reason it may be useful as adjunctive therapy. For treating MS, animal studies have reported a beneficial reduction in tremor and spasticity for marijuana. There's also evidence that it can reduce urge incontinence. Smoking marijuana seems to reduce intraocular pressure in patients with glaucoma. However, it also decreases blood flow to the optic nerve. Presently, it's not known if marijuana does in fact result in improved vision in patients with glaucoma. For the treatment of pain, based on data from animal studies, cannabinoids appear to be mild to moderate analgesics. It's moderately effective according to systemic review of clinical trials comparing various THC preparations to placebo. However, the risk of adverse effects appear to be relatively high. For adverse effects including altered perception and altered cognitive function, the number needed to harm, this is a calculation that they do called the NNH, was 5 to 8, which means that for every 5 to 8 patients who use marijuana for pain, according to these studies, 1 patient will experience these side effects. But essentially, for pain, marijuana is as effective as an NSAID. Now, state laws vary slightly on the specific acceptable indications, but for the most part, they include those conditions that we just discussed. The legislation generally allows for additions of other conditions upon approval from the relative departments of health. In regards to the workers' compensation, where chronic pain syndromes arising from back injuries, for example, are highly represented, most state laws appear to cover this mainly because they do not define the cause of pain. The pain simply has to be characterized as chronic, intractable, or debilitating. Delaware, however, appears to be trying to specify a place in therapy for marijuana by stating that for chronic pain, it has to be a condition that has not responded to previously prescribed medications. This indicates that they're at least trying to designate it as a last-line option. By contrast, the District of Columbia deems marijuana to be an appropriate alternative for drugs known to be more addictive. Now, this is in the legislation, but we bring this up because during our research, we did come across some cases where workers' comp patients have stated their preference for marijuana as an alternative to opioids because they were citing their concern for the addictiveness of opioids. Now, these cases were publicized to a certain degree likely because these patients perhaps felt entitled to compensation for marijuana simply because they are refusing the more stigmatized opioids that have recently been implicated in the rise of drug-related deaths in the U.S. So interestingly, they feel it's not fair for my insurance company to authorize opioids but not marijuana because opioids are such worse medications. California seems to be presenting the most ill-defined set of rules of all the states by allowing the use of marijuana for specifically any debilitating illness where the medical use of marijuana has been deemed appropriate and has been recommended by the physician. There simply does not need to be any scientific evidence whatsoever. It's 100% left up to the physician's discretion whether a drug is okay for a condition. This is where we have to stay a little vigilant because complaints of conditions like anxiety, they can likely be targeted for marijuana. For most people, the primary adverse effects of acute marijuana use is diminished psychomotor performance. Things like reaction time, motor coordination, and visual perception are all impaired. It is therefore inadvisable to operate a vehicle or potentially dangerous equipment while under the influence of marijuana. Some sources indicate that the person's driving ability can be impaired for up to 8 hours. Additionally, acute use can cause dry mouth and the characteristic reddening of the eyes. The chronic effects of marijuana are of greater concern for medical use, and they fall into two categories: the effects of chronic smoking itself and the effects of the THC. Chronic smoking is associated with abnormalities of cells lining the human respiratory tract. So, like tobacco, marijuana smoke is associated with an increased risk of cancer, lung damage, and poor pregnancy outcomes. According to one source, regularly smoking 3 to 4 marijuana cigarettes per day is reported to produce as many symptoms as an average of 22 tobacco cigarettes per day. Long-term THC use is also associated with cognitive impairment. However, this generally develops very slowly, worsens as the years of marijuana use increase, and become clinically significant after about 20 years of use. Additionally, long-term use is associated with apathy, psychic decline, sexual dysfunction, and abnormal menstruation. Now, we highlighted apathy in the previous slide because we wanted to share the findings of a recent article that may be relevant to our discussion today before we continue talking about the risk. The aim of this Norwegian study, which was recently in the news, this study was initiated in 1985 and continued for 25 years. The aim was to examine the association between cannabis use and work commitment. And it involved over 2,000 participants, and like I said, over 25 years. So based on these participants' reports of self-reports of smoking of cannabis, they were categorized into 4 different groups, starting with those who abstained, those who were exposed, simply exposed to cannabis through friends but did not engage in smoking of it, those who experimented, those who basically tried but eventually stopped, and those who continue to smoke, or the involved group. The findings were very interesting in that there was a significant association between the level of work commitment and the level of involvement with cannabis. Initially, those who were involved or had experimented with cannabis displayed lower levels of work commitment than those who were abstaining or merely exposed. Surprisingly, work commitment among those who experimented converged towards the levels of those reported by abstainers and those who were exposed as participants grew older, which means that if they eventually stopped, their work commitment returned to normal. Not surprising, however, those who continued to smoke reported decreasing work commitment all the way into adulthood. Results remain significant even when they controlled for ranges of other factors known to be related to work commitment, such as the socioeconomic background, education, the labor market experience, mental health, and family characteristics. So this is important because, as we will discuss later, the fundamental goal of occupational medicine is to restore occupational functioning. So why prescribe something to an injured worker that will hinder his or her ability to return to work? Back to the risk. The second concern associated with chronic marijuana use is dependence or addiction. It appears, however, that its ability to produce dependence is less significant than that associated with alcohol or nicotine or other drugs, such as opioids, benzodiazepines. Risk factors, though, for marijuana dependence are similar to those for those other drugs, and they include things such as mental illness, history of substance abuse, and younger age. In particular, antisocial personality and conduct disorder are closely associated with substance abuse. According to one source, about 10% of regular marijuana users become addicted. A distinctive marijuana withdrawal syndrome has been identified, but is generally mild and short-lived. The syndrome includes restlessness, irritability, agitation, insomnia, sleep disturbance, nausea, and cramping. Now this slide speaks to the safety of marijuana. According to this, the Substance Abuse and Mental Health Service Administration report, in 2009, they reported slightly over 120 million visits to the emergency department and general purpose hospitals in the United States. And it's estimated that at least 4.5 million of those visits were drug-related. Over 2 million visits were a result from medical emergencies involving drug misuse or abuse. Of all the misuse and abuse visits, about half of these drugs involve pharmaceuticals and half involve illicit drugs. Now, of all the illicit drug cases, 39% were attributed to marijuana. So as we discussed earlier about the DEA and how it continuously has to reject these petitions to reschedule marijuana, we may consider that these statistics may be one of the reasons it remains a Schedule I drug. So at this point, I hope that we have answered a lot of your questions regarding the background, the legal status, and the pharmacology of marijuana. We did our best to structure the information, as some people did post questions in RSVPs. We did our best to answer these questions. If there are any additional questions regarding these specific elements, legal status, background, pharmacology, please keep sending them in. We will try to answer them at the end of the presentation if we have time, and also in a follow-up Q&A report. At this time, we will continue our discussion for medical marijuana as it relates to workers' compensation. And for that, I'm going to hand it back to Phil.
Okay. Thank you, Michael. As you know, most of the presentations I've been doing for probably the last 5 to 6 years have almost all been based on opioids, their misuse and abuse. So it's very interesting to do a presentation now on the possibility of seeing something like medical marijuana entering into the workers' compensation market. But I have to go back to that last slide that you just presented. When we think of the fact that 39% of those cases came from the misuse or abuse of marijuana, that certainly places it in perspective. and it should, in everyone's mind, completely eliminate the notion that was put forward earlier that injured workers are thinking there's an advantage to medical marijuana because of the stigma associated with opioid use. They're both controlled substances. They're both very dangerous. They both have high potential for abuse. But sticking with medical marijuana and its implications for workers' compensation, there's some questions that we want to examine and see if we can answer for the audience today. The first one is specifically an issue for employers, and that's what, if any, accommodations should employers make? And then several questions that could be issues for the payers. How should a recommendation or a prescription for medical marijuana be handled? Where should medical marijuana be placed within a pain management treatment plan? And how can we best prepare for the emergence of medical marijuana during the administration of a claim within the scope of an injured worker's treatment? So looking at the employers first, what accommodations should they make? Well, keep in mind that employers are now operating in 17 states where medical marijuana is legal, and they have to somehow make their workplace drug policies conform to this legality or not. There are a number of questions about this, but let's take a look at this and keep in mind the fact that at the federal level, marijuana is not legal. That has not changed. So the private sector, an employer in the private sector can certainly make accommodations for medical marijuana unless the company happens to handle federal contracts because of the Drug-Free Workplace Act of 1988. So if an employer is making these decisions and they are working with federal contracts, they have to keep that in mind that this would not comply with the Drug-Free Workplace Act. Next comes those employers that have employees involved in transportation, which is going to include pilots, school bus drivers, truck drivers, subway operators, ships captains, etc. They all have to follow the Department of Transportation guidelines. DOT guidelines prohibit medical marijuana for transportation workers. There's no gray area in that. Then it gets a little more complicated when we just consider a general workplace where we don't have transportation workers. We still have to consider the fact that OSHA says that employers have a general duty to provide a safe work environment. I think this is where a lot of employers are going to really be struggling with how to develop policies around medical marijuana. It is important to point out that in 2008, there was a California Supreme Court case that is considered now a landmark ruling where they verified that drug testing is legal and that employers are not obligated to accommodate medical marijuana even if its use was outside the workplace. In addition, Washington State Human Rights Commission has made a statement that they will decline to investigate any claim of discrimination involving medical marijuana. A number of states, as you can see listed there, Colorado, Hawaii, etc., have determined that on-the-job consumption or impairment is grounds for termination. Michigan is included in that list, and it's interesting that Walmart terminated a cancer patient for using medical marijuana, and so far it appears that this worker has not challenged this termination in court. Now, there is actually explicit protection, on the other hand, for medical marijuana written into state legislation for Rhode Island and Maine. In these states, it appears that an employer's duty to provide a safe working environment and not violate federal law or accommodate a patient's violation of federal law supports a reasonable decision to maintain a zero-tolerance drug policy. So very clearly spelled out in these two states. Now, what about issues for payers? How should a prescription for medical marijuana be handled? Well, our position, our opinion on this subject is that no prescription for medical marijuana should be covered. We're basing this on a number of things. Number one, it is not FDA approved. that leaves the question, will it eventually become approved? In the short term, we think that that is very unlikely. The FDA is charged with protecting patient safety, and the manufacture and the production of marijuana at this point in time, we just don't see that is going to ever be something that the FDA could approve. And this also brings up a couple of other topics. Frequent questions that I receive, especially today, are concerning the use of compounds, which aren't FDA approved, as well as off-label use of certain medications. With the amount of concern that I have seen from workers' compensation payers over these topics, I think that the use of medical marijuana should be subject to even more scrutiny than either of these, or at least equal scrutiny. And that simply because they are not approved by the FDA. If something like this was going to be considered, keep in mind that medical marijuana is not covered by any private or public health plans currently. To make an exception for workers' compensation is simply going to perpetuate the notion that injuries that occur and are covered under workers' compensation are somehow different from those injuries that occur outside the workplace. And as we all know, this is not true. So to date, it appears that private and public health plans have chosen not to cover this. And lastly, regardless of the first two, we have to keep in mind that the use of medical marijuana is a violation of federal law. So regardless of whether or not the patient lives in a state where the state considers medical marijuana as legal, we have to consider whether or not the use is advisable under federal law. What about the questions around, well, does medical marijuana have a place within pain management treatment? Well, I think one of the most important things is many states are looking at a number of different guidelines. ODG, ACOM, Connecticut has just updated their medical protocols regarding opioid use, pain management. No state, no guideline currently has a place in therapy for medical marijuana. This is simply based on the fact that there is no evidence-based position for this drug in therapy. The use of medical marijuana is also counterproductive to goals of therapy. As Michael pointed out, the effects of the use of medical marijuana in no way support a return to work program. It is not advisable, and in fact, the use of medical marijuana is considered indicative of, but not medical marijuana, but the use of marijuana is considered indicative of aberrant behavior. We have to consider this, in the overall evaluation of the use of this drug. Now, what about the use of marijuana and chronic opioid therapy, if the two are going to be used together? Well, what we know is, based on a recent study by the National Survey on Drug Use and Health, there is a positive association between cannabis use within the past year and non-medical use of opioids. As a person ages, this association gets stronger. This actually coincides with other patterns that we see, and that is that drug abuse is actually increasing in patients in the same age group. We also see that the non-medical use of opioids in the past year is higher in cannabis users versus non-users by the rate of 10.7% versus 1.1%. We know that the prevalence of cannabis use is multiple times higher among patients in nearly all age groups, and there's a significant association between cannabis use and a spectrum of aberrant behaviors, including opioid abuse and diversion. Obviously, one of the biggest concerns within workers' compensation today. There's also an association between its use and that of illicit substances, non-prescribed controlled substances, in other words, diverted prescription drugs, as well as doctor shopping and opioid trafficking. Now, when we look at a study that was published in Pain Physician about 2 years ago, we see that marijuana correlates with the use of other drugs in a patient population. 21,746 urine specimens were examined. They found 13% incidence of patients positive for marijuana, 4.6% cocaine, and 1.07% for methamphetamine, leading us to the conclusion that there is a correlation between marijuana use and the use of other illicit drugs with a ratio that's greater than 3.7 for other illicit drug use. So essentially, if a patient on chronic opioid therapy comes up positive for marijuana, he or she is almost 4 times more likely to be using other illicit drugs. Based on this research, pain physicians should be aware of this relationship, and marijuana-using patients are at a greater risk for the use of other illicit drugs, increasing their risk profile. And we also know that increased monitoring of these patients could help to minimize potential morbidity due to drug interactions, as well as to identify patients that may be diverting prescriptions in order to pay for illicit drugs. So to summarize, looking at best practices. First of all, we recommend a proactive approach. We feel that payers should begin now to establish an authorization policy for medical marijuana. A baseline urine drug screen must be performed. The payer should insist on an opioid contract or a patient-provider agreement, whatever one may choose to call it, and in advance determine the physician's policy on marijuana. Going back to the question that I staged earlier, why, when the physician has an opioid contract in place, they have a urine drug screen come back that's positive for marijuana, which is a violation of that contract, and yet they do not terminate the patient? That is something that you may want to establish in advance. Now, I want you to keep in mind, too, that when we think about medical marijuana, this is not a traditional medication. It does not have an NDC number. It is not produced in the normal chain from a manufacturer being distributed by a wholesaler to a retail pharmacy. It is not being reported, and therefore, in many instances, it's going to be off the radar, so to speak. So data on this use will have to come from the ability to basically review the bills, incorporate this into programs such as the Alert, Review, and Manage program, where we can analyze claim data, looking for adverse trends. It should also be a factor in assessing risk on these patients. I think as Michael has pointed out in his description, patients are at higher risk once we know of their use. Then there has to be communication between the pharmacy benefit management company and the physician. This would include targeted intervention procedures, making the physician aware of the things that we have discussed today. In many cases could lead to a detailed drug regimen review. If your patients are using medical marijuana, that has to be a consideration when the overall drug therapy is evaluated. And lastly, don't forget the utility of urine drug screening. This is a very important factor for all your patients. Any patient taking controlled substances, but especially those that could be at a higher risk profile because of the use of a drug like marijuana. So with Matt, I'd like to turn it back over to you.
Okay. Please continue to submit your questions in the chat pane. We're going to go through several of them and try and answer them as much as we can in the next 10 minutes with one quick announcement. We will be sending out a white paper on today's webinar. You'll get that via email. The information on your CE credits will come out as well over the next 3 days, and you'll also get a survey on today's webinar to give us feedback going forward. So right now there's a few questions that we've received. One is, how does medical marijuana usage affect a return to the workforce versus narcotics?
Well, as we discussed, marijuana can affect a person's work commitment, and it can affect a person's ability to function safely within a work environment. So essentially, they are a risk to themselves and a risk to their coworkers. Narcotics, on the other hand, although we do see a lot of patients on narcotics that don't go back to work, that is the main therapeutic outcome. There's three therapeutic outcomes, the first of which is primarily reduce pain, and two is to increase the patient's quality of life. The third of which is to improve function. It's one that we do not focus enough on, and physicians do not focus enough on. But if you really think about it, function is the only thing you can measure objectively, because the gold standard of functional improvement is the patient's ability to return to work. So if the patient's coming to you and they're taking narcotics, and the only thing you're measuring is his subjective reports of pain improvements, or whether or not he enjoys his life and enjoys his TV shows, it leaves on the table this possibility that he is misleading you. But if he is in fact going back to work, working 40-hour shifts, earning a paycheck, despite this pain, the medication is basically serving its function, and it's fulfilling its therapeutic goals. And that is what we're looking for.
Thank you, Michael. Next question. Why would medical marijuana be considered only for the terminally ill?
Phil, okay. Well, because of the long-term health risk of, well, first of all, we need to establish that medical marijuana, it's not recommended for anyone from our perspective, but we typically see it. It's usually, the debate over medical marijuana is spearheaded, and they usually use patients that are in terminal conditions, especially in California. You call it the Compassionate Care Act. These patients are cancer patients, patients suffering from terminal illnesses that need marijuana to increase their quality of life. Well, in that respect, there is an international the Institute of Medicine report that says basically, in that case, because of the long-term risk effects, marijuana is not recommended for long-term use, but for patients that are terminally ill, the long-term risk is not of that great concern.
You know, Michael, I want to point out, too, when we're talking about end of life, it brings up another very important subject, and that is end of life is being addressed in the FDA's REMS program. REMS stands for Risk Evaluation and Mitigation Strategy, and that is now a very effective tool in restricting the use of certain opioids, such as Actiq and Ventura, and some of the newer ones like Abstral and Onsolus, where the indication is for terminally ill cancer patients. My concern, though, is even though REMS is being effective in the opioid category of medications, I don't think REMS will ever apply to medical marijuana, since the FDA would consider it an illegal drug.
Yes.
Thank you. Next question. For those patients that are currently on opioids, if medical marijuana is recommended, should the patient continue taking both the medical marijuana and the opioids?
Question is phrased very interestingly. Keep in mind, our position is that we don't see that medical marijuana is going to be a recommended agent under any circumstances. But if we're already down that path, and the patient is going to be utilizing both or considering utilizing both, keep in mind that the effect of the marijuana on the opioid therapy is going to potentiate a lot of the side effects of the opioids. I do not see that there would be a valid use for both, and I would not recommend it. I think if that was taken into consideration, most physicians would agree that opioids would be a better choice for managing a chronic pain patient, assuming validity of the diagnosis.
As a follow-up to that, Phil, we just got one in that I think is pretty interesting, and this is quite interactive, so here we go. In Georgia, a doctor did not see an issue with a patient using multiple opioids who was also positive for marijuana, should an adjuster report this to the medical board?
I would say yes. I would have significant concerns over that. And you know, it appears that the physician was following guidelines. They did the drug screening, but then when they got the results back, multiple opioids and medical marijuana, it causes me concern. Do you agree, Michael?
You got to think about it that medical marijuana is not legal in Georgia, and so that physician is in a position where he's aware the patient is violating the state and the federal law, and he's not doing anything about it. So I think that his integrity, his ethics is in question, and that is essential. That's those essential traits that a physician should have, right? If you or anybody feel like that is a concern, that your physician is not practicing within the scope of his ethical parameters, then I would report it to actually the only board, the only authority that has any say or any way of disciplining him, or even counseling him.
I would agree.
Nobody else can do anything about it.
One last question that came in is, how does marijuana's ceiling effect compare to that of opioids commonly prescribed in workers' compensation?
Ceiling effect? Well, opioids don't have a ceiling effect. And I think in the same way, they don't have a ceiling effect. That's a question we get a lot. What is the maximum dose of an opioid, right, Phil?
That's right.
And we don't. And because of the tolerance that builds to it, what happens, the body gets exposed to this agent, and it creates more and more receptors for it, and so it requires more and more to get the same effect, and it's tolerant dependence. And so the dosage can be varied between individuals. I think that is the same thing that with marijuana. The longer you smoke it, the more you'll need to get the same effect out of it.
Okay. And looks like we have one last question. When an initial report indicates there is a positive toxic screen for marijuana, is there a way to tell if the injured worker was under the influence at the time of the accident? And if so, how long does the drug stay in the system? And would it be legal or appropriate to deny the claim?
Yeah, that's a good question. It's essentially that drug. It's a very persistent drug. It's fat soluble, so it can stay in the body for a very long time. But to prove that a person was under the influence at the time the accident happened, it's going to be a little more difficult. The employer is probably going to have to interview his coworkers and what was he doing. And
if I were the employer in that situation, I think I would definitely seek legal counsel, because that, there is a strong concern over determining that the patient was really impaired at the time, and that's going to be a combination at that point, I think, of both legal and medical opinion.
Yeah, well, we did have a case that we highlighted in our white paper about this, and essentially they could not prove. They had experts from both sides saying that the patient was impaired, the patient was not impaired. In the end, the patient won the suit and was awarded benefits, even though he tested positive for marijuana after the injury.
Okay. Well, I want to thank both of you for providing us with this wealth of knowledge today, and I want to thank all of our subscribers to today's webinar. Thank you very much. We look forward to bringing you more valuable information in the months to come. And as we had indicated, this will be available online for you to listen to again, and you'll be followed up with a few different emails. And we look forward to hearing from you again. Thank you.
Thank you, Matt.